Brandy Rambin from NSU Primetime. We're coming today with a news story on mid-range theorists, and we're going to discuss the chronic theory of sorrow. First off, we're going to go to New Bern, North Carolina with Stacy Causey.
Thanks, Brandy. I'm Stacy Causey. I have the latest news on the mid-range theorist and the theory of chronic sorrow. First up, Georgine Gaskell Eakes. She was born in New Bern, North Carolina. She received her MSN in 1980 from the University of North Carolina at Greensboro. She received her doctorate degree in 1998 from North Carolina State University. She unfortunately was involved in an MBA and resulted in some chronic sorrow. From her experience, she has helped others, and this in turn had helped her in aiding the development of the theory of chronic sorrow. Next up, the theorist of Mary Lehrman Burke. She was born in Sandusky, Ohio. Her education, she received her MSN from Boston University, as well as her doctorate degree. Her catalyst for theory development was her interest in child development. She worked with several spina bifida patients and their mothers. From this, she was able to collect a lot of research and develop the Burke Sorrow Questionnaire. Lastly, Miss Margaret Hainsworth. She immigrated from Ontario, Canada. She received her education, her Master of Science degree in 1974 from Boston College, and a doctorate degree in Education Administration at the University of Connecticut in 1986. She worked in the mental health realm and led a multiple sclerosis women's support group. This in turn led her to the development of chronic sorrow, the theory development of chronic sorrow. This just in. Major practice experiences. First up, Ms. Georgine Eakes. She, as we said earlier, was a mental health nurse. She had a lot of experience with death, dying, loss, and grief. She worked with cancer patients and children with chronic illnesses. She served as a facilitator for prevention and education on SIDS. From all of these experiences, she incorporated the idea which led to the chronic sorrow theory development. This just in. Secondly, Miss Mary Burke. Her experience as a pediatric nurse gave her great excitement in working with children with spina bifida. Her experiences that she learned from dealing with the mothers of the children with spina bifida led to her development of the theory of chronic sorrow. Theory development that Mary Burke had weighed heavily on the theoretical source from Oshansky. Lastly, and our last major practice experience that we'd like to mention to you this evening is Miss Margaret Hainsworth. She was a public and mental health nurse. She also was a certified psychiatric clinical nurse specialist. From her experience, she was able to incorporate with others the development of the theory of chronic sorrow as well. Theoretical sources that were used in the theory development of chronic sorrow were the concept of chronic sorrow by Oshansky, developed in 1962. Also, the model of stress and adaptation by Lazarus and Folkman in 1984 were used in theory development. Primary sources used in the development of the theory of chronic sorrow were three sources that we used in our project as well. The first, the one by Burke, Eakes, and Hainsworth, called The Milestones of Chronic Sorrow. Secondly, the one by Eakes, developed in 1995, Chronic Sorrow, the lived experiences of parents of chronic mentally ill individuals. And the third, by Eakes, Burke, and Hainsworth, the middle range theory of chronic sorrow. And waiting for you guys is Jean Webb from Sandusky, Ohio.
And live from our newsroom in Sandusky, Ohio, we come to talk about how the theory of chronic sorrow is a nursing meta-paradigm. The nursing meta-paradigm is a concept that is made up of four different components: nursing, person, environment, and health. And the theory of chronic sorrow meets all four of these components. It is something that sets nursing apart as a field. The major definitions and concepts of the theory of chronic sorrow are, of course, chronic sorrow to begin with. Chronic sorrow is a long-term grief experienced by patients who have experienced a loss. And loss is specifically defined as 3 different individual groups of people. The first is someone who's experienced chronic illness of some type, whether that's losing a limb or just having a chronic illness that takes them away from the normalcy that they see their life. The second is the family member who cares for someone with chronic illness that changes their life forever and their life as they have to take care of that person. The third is the person who is bereaved, a bereaved family or friend of the person who has just been deceased. And these people experience a grief that transcends lots of time. Chronic sorrow is, as the definition says, cyclical in nature. It has periods where the person experiences life in a normal manner, but then also will have periods of time where their grief just overtakes their life and overwhelms them. There are trigger events that bring the person to this period of grieving and the overtaking of their life. Trigger events can be things such as memories for a person of a deceased loved one, such as seeing a picture of them, or for, say, a chronically ill person, an example would be a teenager who has lost their limb in a car accident and loves to play football, and they're watching their friends play football on the football field. This would trigger them into that cyclical part of the chronic sorrow. Management methods are those that are provided to the patient to help them overcome or at least handle their grief. These can be internal or external. Internal is when the patient does things to help themselves, to let their sorrow out in ways, just not to harbor it in. Those are things that can help the patient on an internal basis. External are things that nurses, for instance, provide for the patient. They provide coping mechanisms and teach them how to deal with their grief. The other 2 definitions that are involved in this theory are ineffective management and effective management. And those are simply, effective management is when the management works, when the person that is experiencing the grief suddenly feels more comfort and less distress. And of course, ineffective management is when the coping mechanisms are not helpful. The major assumptions of the theory are also the 4 components of the nursing meta paradigm, the first of which is nursing. Nursing is a major part of the theory of chronic sorrow. Every nurse should make a part of their assessment assessing someone for the chronic sorrow if they've experienced grief or loss or grief in a recent time frame. They can be there for the patient and just listen to them, and this is often extremely therapeutic for the patient just to have a listening ear. The next component is the person itself that experiences the grief. This person, as we spoke about earlier, experiences the sorrow in cycles. They go through periods of normalcy and periods of overwhelming grief. This can be something that can be helped through nursing, as we just mentioned. The next component is health, and health is determined by how well the person copes and uses these coping mechanisms to deal with their sorrow, and hopefully they end up with a state of good health if they use proper coping mechanisms. The 4th component of the nursing meta paradigm, also the 4th component of these major assumptions, is environment. And environment plays a role by addressing if the person has good social support and family and friends, other people around them to support them during their time of grief and make it easier to go through. When studying the theory of chronic sorrow, it is important to understand that chronic sorrow is a very natural experience for people who have experienced a great loss. This is not a pathological problem, but just something that everyone usually goes through at some point in their life. Pretty much everyone ends up either having a chronic illness, taking care of someone with a chronic illness, or has someone who passes away that's a friend or a family member that's very close to them. So it's very important to keep in mind that it's natural and it's not something to be ashamed of. A common trigger for chronic sorrow for patients and that cycle of experiencing the greater part of their grief is when they realize that their life is no longer the normal that they once thought it would be. whether that's a chronic illness person who realizes that they'll never be able to partake in activities that they used to would have, or whether it's a bereaved family member who realizes that their father no longer will be with them at family events and at Christmas time. This is an escape from the normal that they thought their life would be. And now we'll go over to Robin Burrows in our sister station in Ontario, Canada.
Okay, now we're going to talk about the lifespan. This is the model of the theory of chronic sorrow presented in a schematic type format, which is an excellent visual tool to kind of bring it all together. We'll be talking about some of the same things we've already talked about, talking about the interrelationships of the concepts. And a lot of this, like trigger points, management methods, Jean's already talked about, but we're going to put it all together in a schematic form. First of all, in the theory of chronic sorrow, you're going to have experience of loss, which can be ongoing or can be a single event. Such as when parents have children, naturally they expect them to be healthy. If that does not happen, the child maybe has a chronic illness or some type of serious situation, they will experience loss, which leads to disparity, which leads to chronic sorrow. Now when it becomes chronic sorrow, it's permanent, it can be pervasive, it's periodic, it comes and it goes, and it can also be potentially progressive. That's the goal here, is to prevent the progressiveness of it. So we've reached the point of chronic sorrow. Now is when the management methods come into play. And the better management, of course, the more likely you would not have it become progressive. Management methods can be internal or external. External management methods are those that are implemented by others, like healthcare professionals. Internal management methods are those that are implemented by the person themselves. Certain things that they do to manage the chronic sorrow, such as maybe joining a support group, letting their emotions out through talking or through crying. Those type things are considered internal. Maybe joining a support group. Those are things they do themselves. Now, internal and external management methods both can be either ineffective or they can be effective. If the management method is effective, then this is evident by decreased feelings of regrief, which will lead to decreased comfort, which will lead to the cycle, the pattern, which we said operates in a cycle. Now, if the management methods are ineffective, then this will lead to discomfort and will lead to trigger events, and then the cycle just repeats itself. And we talked about some trigger events earlier, but trigger events are different for different groups of people. You have your chronic, you have your person that actually has the chronic illness, you have your bereaved persons, and you also have your family caregivers. And they each will experience different trigger events. Now, all three of these groups of people have the common trigger events of anniversaries will trigger chronic sorrow, and comparing to norms. Those are common for all groups. Whereas your family caregivers, the most common trigger events for them would be unending caregiving. You don't really know when it's going to end. And as far as bereaved persons, and things like trigger events also too, like changes in roles, that type of thing. So as you can see, it's a cycle, and the goal being good management methods, effective, so that you prevent the progressiveness of the chronic sorrow. And now I'm going to turn it back over to Stacy Causey.
Thanks, Robin. On to the logical form. The theory of chronic sorrow was founded on a sequence of qualitative research studies that interviewed 196 interviewees. Empirical data was used to describe the phenomenon of chronic sorrow. In addition, data used to identify common triggers, and then also coping mechanisms and nursing management were described in the theory development. On to relationship of theory. Via the heading of nursing research, extended research continued to include populations such as HIV, diabetes, and sickle cell. Nursing education from the theory of chronic sorrow was the development of the NANDA diagnosis that we still use today as part of our nursing diagnoses. Chronic sorrow also focuses on outcomes that's important when teaching evidence-based practice. As advanced nurse practice agents, many patients with chronic diseases experience chronic sorrow. It is important for us as nurse practitioners to have a strong knowledge of the base of the theory of chronic sorrow. To conclude, let's go back to Brandy Rambin at NSU Primetime.
Hi, I'm Brandy Rambin back at Primetime NSU. We're going to discuss how vital the chronic sorrow, or the theory for chronic sorrow, is for the advanced nurse. It is very important because it gives us the ability to diagnose patients and actually treat them for this. There are 3 roles that were discussed by Eakes, Burke, Hainsworth, and Lindgren in a 1993 article that discusses the 3 roles of the advanced practice nurse. One which was empathy, which is very important so that you can actually understand where the patient's coming from and the grief that they're going through. Expert teaching was another role that was critical for the advanced practice nurse to have so that they could explain how this is normal and how to work through it and get some normalcy back to their life. And then the caring and being a caring and very proficient professional is also very important because you need to know what you're talking about and you need to be able to extend out and have knowledge of help for these patients. A case summary that we're going to discuss is a gentleman by the name of Ralph Pisario. He is currently a 43-year-old male, had contracted dilated cardiomyopathy from a virus at the age of 38. He is now debilitated, unable to return to work, has not applied for disability, and is currently married with a son at the age of 13 years old. The wife, Anna, was seen in the clinic by the advanced practice nurse, and after listening and giving time with her, she did realize that, again, her husband's not on disability. The wife is under a lot of stress working 2 jobs and also trying to care for their 13-year-old as the husband's not able to go back to work or provide much assistance in the caring for her son. He's been very weak and unable to do normal chores that other husbands are able to do. She does get frustrated at times with the husband, but also empathizes with her husband. It's very sad that he cannot do the things that he wants to do, and also the things that she needs done. The wife does cope well by keeping busy and taking her son to ball games and making sure he's staying active in things. She also includes her husband by getting him and taking him to the games as well, making sure that he has a chair that is close by for them to sit in. She is very thankful, however, that she does still have her husband, although all this is going on. It was very important that the advanced practice nurse was able to talk to her and reassure her and let her know that these are normal feelings, that not to feel guilty over having these different anxieties and fears and even frustrations. It's very important that the advanced practice nurse was up on many different areas as far as letting her know that she could apply for disability for her husband, which would bring in some money to help with bills as far as medications and different hospital bills, as well as the other little things that they need in life. Making sure that she gets with a support group of other women that are going through the same similar issues that can also guide her to the areas that she needs help in as well. After a strategy is made for this type of patient, it's very important to go back and recheck and reassess to see how she's doing, see if these things are helpful, and if not, changing things to where she can get the best comfort from the strategy. As we know, that this is, as we've been told in other presentations, that it is cyclical, so it is very important to recheck and reassess and regroup. Thank you for joining us at NSU Primetime. Have a good night.